Fahad, we cannot hear you. I think your mic is unmuted. You need to unmute.
So I was saying thank you, Shadi, and thank you, Mitab. And our next speaker is Dr. Ahmed Alwbari, who is a consultant medical oncologist in King Fahad Specialist Hospital, and he leads the breast group in our practice in Dammam. So Dr. Ahmed will talk to us about PARP inhibitors in treatment of early breast cancer. Dr. Ahmed.
Assalamu alaikum. I was trying to unmute myself. Thank you. I'd like to thank the organizers for the invitation. Fahad and Shadi, thanks for the introduction. I am going to talk about PARP inhibitor in early breast cancer. I thought that this is an important topic that doesn't get covered as frequently as one would like. So this is my disclosure. And the outline of the agenda today is a biology, then we'll talk about early breast cancer clinical trials, and then we'll touch on the new or the ongoing exploration beyond germline mutation of BRCA. So we know that the BRCA mutation tends to affect younger age patients, and it happens in with a higher rate when it comes to, higher grade when it when there's pathological review of the slides. Patients with BRCA, they tend to have more CNS metastases, a little bit more than the ordinary when it comes to contralateral breast cancer, and obviously higher risk of recurrence. So the average risk of breast cancer developing in a patient at 70 years really varies from one article to another, but in general, it's 50 to 70% average risk. And the germline mutation BRCA1, BRCA2 accounts for roughly 10% of familial breast cancer and 20% or even more in our area. The mutation BRCA1 is mostly associated with triple negative, and BRCA2 is associated with hormone positive as a rule of thumb. What happens in BRCA mutation, remember that BRCA gene is a normal gene. So it stands for breast cancer gene, but in fact, it's a tumor suppressor. So when BRCA is mutated, the cell loses the homologous recombination, and it tends to look for other mechanism of DNA repair, including base excision repair, where PARP inhibitor really inhibit that mechanism and leads to cellular demise. PARP inhibitor does not inhibit base excision repair only, also affect the non-homologous injunction and other mechanisms. So it seems to, in the lab at least, to be a very powerful tool to inhibit DNA repair in patients with BRCA positive. We certainly know that BRCA can happen in a germline fashion, so all the DNA of the human being is affected, or just in a somatic alteration fashion, where only the tumor cells gain BRCA as a mechanism of defense for the tumor itself, and while leaving, obviously, the germline intact. So with almost all of the discussions in the previous conferences were about BRCA and metastatic, today we will try to address early breast cancer, and we'll start with neoadjuvant. So in the neoadjuvant setting, quite few studies have been conducted. Majority of them are phase 2, and they are actually small studies, but we, you start with baby steps and you build on them. So the first one was the MD Anderson neoadjuvant talazoparib for patients with operable BRCA positive. The idea is to see if we can turn these patients, if we can improve PCR, and as Mit'ab said, the RCP, which is 0 to 1 or 0 preferably. So these are only 20 patients who has had stage 1 to stage 3 breast cancer with triple negative germline mutation. They were randomized to receive, this is a single arm, to receive talazoparib for 24 weeks, and then surgery with a primary endpoint of PCR and RCP 0 to 1. And the results actually was fairly good. So in these patients, 10 of them have achieved PCR and RCP 0 to 1 at 1/19. That does not affect only the triple negative, or it also, the PCR was also seen in metaplastic carcinoma and lobular carcinoma, which are rather notorious pathologies or histologies not to respond to chemotherapy. So that was a good sign. In the I-SPY 2, it's another phase 2 trial where patients with hormone positive or negative, HER2 negative, stage 2 and 3 with measurable disease, they were randomized to receive standard of care chemotherapy, a standard of care with added vilaparib and carboplatin. With the primary endpoint here is PCR. And I'll show you here that the PCR in the triple negative certainly was rather superior. In fact, the triple, in the vilaparib carboplatin group, the PCR was 51% compared to 26%. In the HER2 negative group, the PCR was 33% versus 22%. So it really improved the PCR certainly in the triple negative. And as you can see here, that the demographic of the patients, the majority of these patients were white as expected, and hormone receptor 50%. And then the balance between the two groups was fairly good. So this is the result that I just showed you in a tabulated form, that the triple negative PCR improved significantly with vilaparib carboplatin. Now that obviously came with side effects, hematologic side effects certainly, adding a PARP inhibitor that induces hematologic suppression with carboplatin that's known to have hematologic suppression also. So you expect more of neutropenias and anemia and thrombocytopenia. So the bottom line from the I-SPY 2 is that the higher rates of pathologic CR that was seen in the triple negative indicates the activity of vilaparib carboplatin combination added to standard chemotherapy. The next trial is the brightness. The brightness is rather a larger trial of previously untreated women with stage 2 and 3 triple negative who have documented germline BRCA, 634 patients. The randomization was as follows. One is to vilaparib carboplatin plus paclitaxel. Next is placebo carboplatin paclitaxel, and the third one is placebo paclitaxel. So the bottom line here is that the first one has vilaparib and carboplatin to the paclitaxel, and then they drop the vilaparib, and then in the third one they drop both of the these agents. All of these patients will go to receive anthracycline-based doxorubicin, so they complete the standard of care treatment. The primary objective here is the PCR in breast and axilla, and the secondary endpoint conversion to breast-conserving surgery eligibility, EFS, and OS. These patients, this is the neoadjuvant chemotherapy patients' characteristics. As you can see, that they are well balanced between the groups. Majority of these patients were T2 and about only 11% were T1. Majority of these patients have lymph node positive. In 0 and 1 was 57%, and in 2, 43%. And some of them received dose dense AC versus Q3 55 to 44. And as you can see here, the orange has the carboplatin and veliparib, and the gray has carboplatin without veliparib, and the blue lines of bars have no carboplatin and no veliparib. So clearly, the blue, the blue is inferior to the other two bars. But when you can take a look at the PCR, you see that the PCR rate in veliparib carboplatin numerically actually is lower than the carboplatin alone. And then we'll just take it from there. So when you take a look at the first plot, when you compare the veliparib arm with carboplatin compared to no veliparib with carboplatin, you see that the lines sit on the hazard ratio, while when you compare any of these regimens to the taxane alone, it seems that they favor the addition of carboplatin and veliparib. And once again, you add a PARP inhibitor to a carboplatin, you increase the incidence of hematologic and GI toxicities. And these of any grade, anemia of any grade, and neutropenia of any grade were 70%, 61%, and 70% compared to 17 and 53. So the bottom line from this trial is that veliparib carboplatin taxane followed by AC significantly increased the PCR over AC and taxane alone, 53% versus 31. The addition of veliparib did not improve the PCR rate, and probably the benefit of the regimens that have veliparib, the benefit was from carboplatin, seems like. And the other thing is that there is no clear impact on germline BRCA1 and BRCA2 on the PCR rate, and obviously increased toxicity with the combination. The next one is the Immualta, which is utilizing talazoparib in the neoadjuvant setting, a larger population at this time compared to the first MD Anderson that I presented. This is the primary endpoint here is PCR by independent review. This is still ongoing. And the partner study, which is using olaparib this time in combination with carboplatin and without carboplatin, and with the primary endpoint safety, PCR as a secondary endpoint. Again, this is an ongoing clinical trial. So let's move on to more exciting part of the talk, I guess. It's the adjuvant part. From the Olympiad with the D at the end, Olympiad, it resulted in the approval of olaparib in the metastatic setting with germline mutation, regardless of the hormonal status, or hormone positive or negative. This was a recently published results, the Olympia trial. The Olympia is in the adjuvant setting. And let's take a look at the study design here. So men and women with germ mutation, high risk primary breast cancer completed the neoadjuvant or adjuvant chemotherapy, the standard of care chemotherapy, and then they get randomized to receive to two groups first. The first group is the TNBC, which is the majority, the triple negative, 1,500 out of 1,836. The patients with triple negative, they should have no PCR, or if they have adjuvant therapy, they should have one or two, P in one or more, or PT2 or more. The hormone positive with prior neoadjuvant have no PCR, or the CPS plus EG score more than 3, and if they have 4 or more lymph node positive, and there were 325 patients. The randomization was to receive olaparib for 1 year versus placebo for 1 year, with a primary endpoint of invasive disease-free survival, a secondary endpoint distant disease-free survival, overall survival, and safety. Patient characteristics, a little bit more skewed to BRCA1, 71% versus 28% BRCA2. As far as adjuvant and neoadjuvant, the balance is okay, 50-50. The anthracycline plus taxane regimen, almost all patients have received that. There were premenopausal, 62% compared to postmenopausal, and that's expected given the BRCA is a disease of young people, or BRCA-associated breast cancer, I should say. And the triple negative is 81 compared to hormone positive 18. So I think that this really reflects what we see in reality. And not surprisingly, probably that the invasive disease-free survival came to be positive. It reduces the risk of death and recurrence by 42%. The absolute benefit is 8.8% in terms of invasive disease-free survival. So the olaparib at 3 years, invasive disease-free survival was 85.9 compared to 77.1. One of the secondary endpoints is distance disease recurrence, which was halved by the use of olaparib, including CNS metastases. So CNS and non-CNS metastases were reduced significantly with olaparib, 50% compared to the placebo arm. So a follow-up 3 years invasive disease-free survival showed maintenance, or that the benefit has been maintained over the years, and the difference is 8.6. So that's the 3.5 years follow-up is also reassuring. Looking at the 3 subgroup analysis, clearly olaparib really benefited all the subgroup. You see some in larger confidence interval in certain subgroup, including previous platinum. Yes, so the use of platinum can increase the confidence interval. Still, it's on the favor of olaparib. And then the distant disease-free survival has also been reduced by olaparib, and with the absolute benefit of 7.5. So the olaparib arm was 87.3, placebo was 80.4. The overall survival did not really, the number of events did not reach the statistical threshold, though the numbers, the hazard ratio of 0.68 and the p-value of 0.02 with a difference of 3.7, but this is still blinded, and there'll be ongoing follow-up to see whether overall survival will gain momentum with further follow-up. So what we actually know that from the metastatic setting with the use of PARP is that these are not chemotherapy, but not exactly hormonal therapy. So they tend to produce side effects that result in discontinuation of dose reduction. But here in this clinical trial, 70% of patients completed the treatment according to the protocol without the need for dose reduction. And I thought that this is a very reassuring that you are in the adjuvant setting. You want to maintain quality of life of these patients. You don't want to really induce side effects and make patients miserable. So this is a very good sign to me. And only 10% discontinued olaparib due to adverse event, and most of these adverse events were the most common that led to discontinuation of nausea and anemia. And it's also good to know that grade 3 and grade 4 side effects were 25% out of the all adverse event that happened. So the majority of patients will have side effects that were not grade 3 and not grade 4. And the most common anemia, grade 3 that occurs more than 50% is actually anemia. That said, the anemia, it seems like, did not require lots of transfusion. So if you look at the patients who have received single transfusion, is out of 5.8% who developed anemia, only 4.1 received single transfusion. 2 transfusions, 1.4%, and almost 0.3%. So it seems like a patient or less than that who received 3 or more blood transfusion. So it's fairly well tolerated, and the degree of transfusion is not huge either. And then the other thing that I was just mentioning a while ago, that the health-related quality of life is very important, especially in the adjuvant setting. And here it tells you that whether you give neoadjuvant or adjuvant chemotherapy, olaparib did not impact the health-related quality of life negatively. So the bottom line here is that in the Olympia, it improves the invasive disease-free survival with absolute benefit of more than 8%. It reduced the risk of distance recurrence by half. The side effects were very well tolerated. The overall survival was not met yet, but we are going to follow the clinical trial to see if overall survival benefit pans out in the future. So now just quickly expanding beyond germline BRCA mutation, as I mentioned earlier, that there are a subset of patients who have somatic alteration, or there are patients who have germline mutation that is considered to be of a BRCA-ness, similar to BRCA in behavior, but they are not actually BRCA positive. So the LUCI trial is a phase 3 trial that will include patients, 250 patients with, excuse me, in the metastatic setting, with treated with taxane and anthracycline, and they will be randomized to receive olaparib. These patients, they will enroll patients whether they are germline or somatic mutation, with the primary endpoints progression-free survival. The RUBY has also included patients with the BRCA-ness, meaning there are mutations that they may resemble BRCA mutation, but not necessarily BRCA genes. And again, this is rucaparib that will be the drug of choice, and the treatment also in the metastatic setting, second-line metastatic setting, until disease progression. The primary endpoint is the clinical benefit rate at 16 weeks. And then also there is the phase 2 study of olaparib in metastatic with DNA repair mutation, including BRCA1 and BRCA2. And also these are adults with deleterious or suspected deleterious DNA repair. That also will include other genes that you can see in the box. Excuse me. In the right hand side, there are many genes that will be included in an array of genes that are not necessarily BRCA1, BRCA2. Some of them will have BRCA1, some of them will exclude actually BRCA1, BRCA2, and olaparib until disease progression with overall response rate being the endpoint. Also, this is actually a study that will incorporate olaparib in excuse me.
And maybe we have only 1 minute.
Yeah, that's I'm about to finish. This is incorporated concurrent chemoradiation with olaparib in inflammatory breast cancer, obviously with invasive disease-free survival as primary endpoint, and this is also an ongoing clinical trial. Thank you very much.
Thank you very much, Dr. Ahmed Alwbari. And so we start our question and answer session. And we are short of time. So I think, Dr. Shadi, we agreed to limit questions.